afternoon, everyone. My name is James Orbinski. I'm the principal here at Massey College, and I'm delighted to invite all of you and to see all of you here at this really, really important conversation. The title of today's afternoon discussion is Healthcare Barriers for People with Disabilities, a view from the front line. I would just let me begin at first by acknowledging the land that we're on here at Massey College, in the U of T, in Toronto. And this is the traditional territorial area known as Takaronto, and its treaty holders are the Mississaugas of the Credit First Nation. It's also the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Seneca and the Haudenosaunee Confederacy, the Huron-Wendat, and of course, the Métis. And this territory is subject to the Dish with One Spoon Wampum Belt Covenant. And this is an agreement to peaceably share and care for the Great Lakes region. And this also includes the people, all people in this region. And this, of course, includes people with disabilities. I'm delighted that David Lepofsky is here today as our lead panelist, I think is probably a nice way to put it. And David, over a truly stellar career, has shone a light on the inequities that are entirely remediable, and inequities that impede people with disabilities from accessing a fundamental service, and today we're talking about one of many fundamental services, healthcare. Access to healthcare for citizens, for all citizens, including those with disabilities, is really fundamentally predicated on a recognition of the dignity of each and every person, and that dignity that underlies citizenship and that underlies any claim to a right to be able to access healthcare in this particular example. And engaging an inclusive approach to access, it must not simply be a normative concept. It has to be very much about actions. It has to be about actions in policy, in practice, and in creating the enabling conditions that allow for a person with a disability to be included and not to be structurally excluded from access to healthcare. I'm a medical doctor with many years of practice and many years of different types of settings. And I've witnessed firsthand the barriers that people with disabilities face in accessing healthcare, whether that's in war zones, whether that's in HIV clinics in Malawi or in Indonesia, or whether it's in my role, my previous work here in Toronto at St. Michael's Hospital in downtown Toronto. And I'm very glad to see that there are so many here today to advocate for inclusive healthcare. And again, not just in emergency treatment, but also in creating the enabling conditions that allow for access and that overcome structural barriers to access. All of this fosters independence so that all citizens, including those with disability, are free and able to be their best selves as human beings, but also as citizens. Our moderator today is our very distinguished Massey College Senior Fellow and member of the Massey College Governing Board, Professor Gillian Kohler, a dear friend of mine for many, many years. Dr. Kohler is a professor at the Leslie Dan Faculty of Pharmacy, at the Dalalana School of Public Health, and at the Monk School of Global Affairs. She's also founding director of the World Health Organization Collaborating Center on Governance, accountability, and transparency in the pharmaceutical sector. And she's also recipient of many awards, but the one I'll just mention most recently is the 2024 Canadian Integrity Award, given by Transparency International Canada. With that, I welcome you to Massey. This is exactly the kind of dialogue and discussion that Massey is committed to. We are committed to cultivating civility and leadership for the public good around issues of contemporary concern. There is absolutely no doubt that access to health care for people with disabilities is an issue of contemporary concern. And with that, I will invite Jillian to begin the panel. Thank you.
Thank you so much, Principal Orbinski, and it's really a privilege today to be here and to be part of this important conversation. And it is my honor to introduce our lead speaker today, but before I do so, I'll just quickly go through the structure. We're going to try and make this as informal as possible. There are people online, so we'll try to engage with the people who are watching us from the virtual world as much as possible as well. David will be beginning with his overview of some of the points he wants to make for our discussion, and then we're going to follow up with questions from our two amazing junior fellows who I will introduce later, and then we will invite the audience to participate in this discussion. So in light of David's tremendous accomplishments, I cannot do him justice by going through his bio today without taking up literally the entire session. So you have all received a copy of this in your registration email, and I'll just highlight a few things. David Lepofsky is a visiting research professor at the Faculty of Law at the University of Western Ontario, a past visiting professor of disability rights and legal education at the Osgoode Hall Law School, and for over 3 decades, an adjunct member of the University of Toronto Faculty of Law. He is chair of the Accessibility for Ontarians with Disabilities Act Alliance. He is a member and past chair of the Toronto District School Board Special Education Advisory Committee. From 2018 to 2022, he served as a member of the Kindergarten Grade 12 Education Standards Development Committee, appointed by the Ontario government to recommend reforms to tear down barriers impeding students with disabilities. He is also a member of the board of the Ontario Parents of Visually Impaired Children. David has received many, many incredible awards, so I'm just going to name a few of them, including the Order of Canada, the Order of Ontario, and the Terry Fox Hall of Fame. And I will stop there, David, because again, as I mentioned, there's so much that I could say about you. What I will say is that we are delighted to have you today. We welcome you, and we look forward to our discussion. So thank you very much. Okay, and then the microphone is just right here.
Got it. Thank you very much. It's a tremendous, tremendous honor to be here. There are 2 people I want to single out and tell you not to listen to them. My wonderful friend and former member of the Court of Appeal, Susan Lang, and my wonderful friend and former Chief Justice of the High Court, Patrick Lesage. They are wonderful, they are brilliant, and they had to listen to my arguments and skillfully reject them. Don't listen to them. What an amazing opportunity. I welcome this. We live in a society that is built, organized, and operated on an overwhelming, pervasive, little recognized, and absolutely absurd premise. How's that for an opener? Our society is overwhelmingly operated on the basis that it is for people without disabilities. The public transit we ride, the buildings we go to, the schools and universities where we study, and the curriculum and content that's delivered there and the manner it's delivered and evaluated. The workplaces we work in, the stores where we shop and the products we buy there, even the laws that we live under and the courts that implement and oversee them are all overwhelmingly organized on the basis that they are for people without disabilities, not those with a mobility disability, such as those who use a wheelchair, those with a sensory disability, such as those with hearing loss, or people like me who are blind, those with an intellectual disability or a psychosocial disability, those who are neurodiverse, those with any kind of disability. The barriers we face in our society are physical barriers, technology barriers, policy barriers, legal barriers, and in many cases, just plain stupid bureaucratic barriers. Yes, there are lots of them. Now, before I go further, we're in an institution of higher learning where we critically study things, test them, and try to evaluate them for their reliability. So I want to do a little survey study with you. It is completely unscientific, and therefore, Justices Lang and Lesage, completely admissible in your courts of law if I'm trying to adduce them. I want to see if this topic touches your life. Could you please raise your hand if you have no disability now and you are certain you'll never get one for the rest of your life? Raise your hands, please. I don't see any hands. I never see any hands. You and I are part of the weirdest minority of all. We are the minority of everyone. Everyone has a disability now or is bound to get one later. So, when I say absurd, I really mean absurd, because we live in a world that is largely designed and operated as if the minority of everybody isn't going to try to participate in it at some point in their life. This ain't clever. Now, I don't for a moment suggest that this is deliberate, that there's a conspiracy. But you know what? If there had been a conspiracy and if it were deliberate, the world would not look one bit different than it does right now. So whether it's deliberate or unintentional doesn't matter. Now, I'm working as a law professor part-time now that I've retired from law practice. And you heard I'm at Western. I'm also a visiting professor at University of Ottawa's Faculty of Law. So let's do some law. It's going to take 30 seconds. You ready? All of these disability barriers are illegal. Done. That's it. The only remotely legally interesting question is a remedial question, how long organizations have to fix it, but that these barriers have to go as a matter of law is not an arguable or debatable point. They violate the Charter of Rights, guarantee of equality to people with disabilities. They guarantee the Human Rights Code, guarantee of equality to people with disabilities. They violate the objective of accessibility legislation, like the Accessibility for Ontarians with Disabilities Act. These three laws are really important, and they're also very weird. What's weird about them? Those of us who study or practice law deal extensively with endless laws that are passed in legislatures and in Parliament in Ottawa. The vast, vast, vast majority of them did not come from the people. They came from the halls of the public service or the political platforms of parties. These three laws are different. They came from us. We people with disabilities fought for them. I had the privilege 45 years ago of being involved in the fight to get disability into the Charter of Rights. If you want to read about it, I actually wrote a memoir about it. It's available, and I'm not going to make any money. It's free. It's called, you ready? Google this. Swimming Up Niagara Falls. The link to it, to download it for free, is in the links I've provided for today's talk. But if you really need a hard copy, it's also available as a print on demand. The disability amendments to the Human Rights Code. I was involved with many other people with disabilities in the fight for the Charter of Rights, equality guarantee to us, and the Human Rights Code, equality guarantee for us. And from 94 to 2005, I led the fight of our community for the Accessibility for Ontarians with Disabilities Act. So these barriers were all illegal, and we were the ones who insisted on the laws to make it so. So let's zero in on healthcare. That absurd principle is as pervasive in our healthcare system as it is in our education system, our justice system, and all sorts of other places. Now, don't get me wrong, I'm not saying that there's nothing for us, or some people aren't trying to work around, but the workarounds are afterthoughts. In education, let's build an inaccessible education system and then slap on something called special education. Oh, there isn't enough money for that? Oh, well, listen, we're spending more than ever of the inadequate money we're providing to try to piece together a system we're running totally on the wrong premise, and so on. There are some things, but the healthcare system is replete with disability barriers. There are, beyond being like absurd, there's a couple more reasons why this is absurd. First, it's overwhelmingly funded by the public. This isn't the private economy somehow getting it wrong. This is a government-managed program getting it wrong. And the second, we got enough absurd here, but there's one more absurd for you. Disproportionately, the people who use the healthcare system are, permanently or temporarily, people with, you guessed it, disabilities. So, massively publicly funded, overwhelmingly serving people with disabilities, full of disability barriers. I'm not making this up. I'm just telling you about the world I can't see. Now, let me give you some examples, because saying these kind of grand things is great, but let me give you some examples. A few of them are specifically blindness related, but this pervades all disabilities. In fact, the Canadian Medical Association Journal has a podcast. I can't remember what it's called, but look it up, subscribe. And about a week ago, I think, they ran a whole episode on this. And before I was interviewed, but before me, there was this unbelievable interview with a doctor named Lisa Friedman who uses a wheelchair. She didn't talk about the barriers to her practicing medicine as a person with a disability. She talked about the barriers that she faces as a patient with disabilities. And she's a physician, being sent to specialists whose offices are inaccessible, or medical offices whose diagnostic equipment's inaccessible. This is like here. We're not talking about some country that's bankrupt or, lacks a developed healthcare system. But let me give you some of my own. So you got to go to the doctor, or you got to go to the hospital. You walk in the front door, first thing you want to know is where the hell's the office you got to go to? There is no Walmart greeter. You can't find your own way. Asking people can be futile because nobody knows where the hell anything is, including the people who work there, because hospitals are not designed to make it easy to find your way around. Who'd have thought people coming to a hospital would need to be able to find their way around? What a ridiculous concept. We'll see new ones built that are gorgeous, that are stunning, that are art pieces. But they still have this problem. There's no Walmart greeter. I mean, this is not rocket science. When you get to the elevator, you happen to be blind. I don't read print. How do you select your floor? A whole lot of them don't have Braille on the elevator buttons. Who thought that blind people might need Braille on an elevator button? Go to any hotel in the United States, they thought about it because their Congress mandated these kinds of accommodations in 1990. Then you get to a doctor's office, whether in a hospital or in a private office. And what may be the first step is you're given a medical history form to complete, either on paper or on an iPad. Both cases, unless somebody does something about it, not accessible. Now, iPads have accessibility features built in, but unless you make sure that the app is accessible and that the patient knows how to use iOS accessibility features, it doesn't matter. But instead, you get a printed form to fill out. And if you go to the front desk and ask for some help, they're often, quite willing to help you. But believe it or not, I've experienced, and not unique to me, where they literally sit there from the counter, the check-in desk, and say over the open waiting area full of other patients, start asking you these questions about your private medical history. What communicable diseases have you had? Oh, I really want to be asked that in public, especially sitting next to strangers. I mean, I'm sure they're listening. I would too if it was turned the other way around. But I mean, and if you say, now I, as you may have gathered, have managed to overcome my shyness. So I will be inclined to say, excuse me, can we find a private room and we can talk about this? But lots of people don't even know you can do that. Then you get to the medical appointment, and this, by the way, I'm talking about a system that is surrounded by people who care, doctors who care, medical staff who care, allied health professionals who care. This is not bad people. This is a bad system. I told you about problems where someone like Lisa may not be able to get on the diagnostic equipment, or you need assistance and it's not available, or you need more time than the 15 minutes the government funds for the appointment, or you need Wheel-Trans to get to the appointment. Wheel-Trans has to be booked well in advance, notoriously capable of being late. You book it way early and you still arrive late, and what you're told is you missed your appointment and you have to pay a penalty fee for missing your appointment, thanks to Wheel-Trans not being a reliable transit system for people with disabilities. These are all like real kinds of things that happen. After you're diagnosed, now here's just two more from a blindness point of view, and if we substituted in what deaf people go through or people with other disabilities, we could just, this would be a much longer talk. But this just gives you a sense. At the end, you get your diagnosis, and helpfully, the healthcare provider may have a brochure to tell you what's available, or to provide an explanation of the condition in print. And if you say, I'm sorry, I can't read print, can I get that in an accessible format? That's nobody's department. But then you might get a prescription. Jillian, this is for you. Then you get a prescription. So you go to the drugstore. Now there's two things you get when you get a prescription filled. One, both of them are really important. The first thing you get is the actual pills or other medicine. And the other thing you get is the prescription label. It tells you what's in there. It tells you the dose to take, when to take it, whether to take it with food, and so on. In print, and I'm told, in really small print. Disproportionately, who uses a lot of prescriptions? Older people. Disproportionately, who experiences vision loss? You guessed it, older people. Now, in the United States, for years, they've had companies that will provide accessible prescription labels. They type a little thing on the label, you are provided a little scanner thing. Now you can use your smartphone, scan it, and it'll read it to you. And in a number of the major chains, thanks in no small part to a friend of mine who's a disability rights lawyer in Berkeley, major providers, major pharmacies provide these straight up. Here, not so much. I walked into my local pharmacy and they said, well, we don't provide it. I'm told that ethically I should tell you that you can go to the Shoppers across the street. Now, can you imagine saying, we don't serve blacks? But they do go there. That would not go over so well, nor should it. And when I made that comparison, I was not well received by the pharmacist who I said it to. But not only that, I went across the street to that shoppers. They said, no, we don't provide it either. We don't know any drugstore who does. Now, if you go to the Human Rights Code and litigate it, you might win against one, but that's like one pharmacy, one branch. It won't go any further from there unless you want to litigate against the next one. So what do we do about all this? What do we do about all this? I've given you just a few snapshots in a short time. I could give you tons more. You could give me even more. What do we do about it? Well, all of this is illegal under the Human Rights Code. You can go file a human rights complaint, and thanks to our current government, you can now wait a good 5 years to get a hearing, if at least 5 years. Or you could, and so, I mean, and you got a winning case, but like, who's going to go through all that? If we litigated all the barriers we face in our daily lives, we'd have no time to go to the bathroom. I've done it. I fought the TTC to force them to announce subway and bus stops. I won, but it only took on and off about 12 years. And I know how to practice law, and I had a couple of really good pro bono lawyers who helped out. Most people aren't going to go through that. So what do? That's why we fought for the Accessibility for Ontarians with Disabilities Act. It's a law not to replace the Charter of Rights guarantees or the Human Rights Code guarantees, but a law that would put them into effect in our lives without us having to fight one barrier at a time and be private accessibility cops in the process. And the way it's supposed to be done is by the government enacting a series of regulations called accessibility standards. And those accessibility standards on a sector-by-sector basis will identify what an organization has to do, when, and sometimes how, to become accessible. So we have a transportation standard. It now tells everyone, thanks to my winning that case, that all public municipal transit authorities have to announce all route stops. That's the law. Doesn't mean they're obeying it because the AODA is poorly enforced, but that's the law. We have a standard for accessible employment. What we don't have is a healthcare accessibility standard. And in leading my coalition, we've been fighting for one since 2009. Now, after 6 years of fighting, the then government, under Kathleen Wynne, announced that they would enact a healthcare accessibility standard. They announced that in February of 2015, 10 years ago. We still don't have one. It took 3 years to get them to take the next step. They appointed an expert panel to recommend what that regulation should include. They also tied its hands by saying it could only talk about hospitals. Most people get most health care outside hospitals. And telling people with disabilities, in effect, that the only accessible place you can get health care is in hospitals was rather self-defeating. But in any event, it was an expert committee, half from the disability community, half from the health community, and it rendered a comprehensive report 3 years ago saying what this standard should include. It's not a bad report. There's some things I think should have been in there that weren't, but whatever. We could sit down with the government and go through that, except the current government had no interest. And in the 3 years since it was these recommendations were made and were made public, absolutely nothing's been enacted. It wouldn't surprise me if I was to talk about this in a healthcare setting, like a hospital, that they wouldn't even know there was a report. It wouldn't surprise me if allied health faculties at this university, the faculty and the students would likely not even know there was a commitment 10 years ago, or a comprehensive report, and so on. It's just not even in the fabric of the healthcare system to look at this. Now, there are, within hospitals and other organizations, offices trying to implement the weak AODA standards that have been enacted to date, but it's seriously incomplete. So what do we do about it? Well, I can tell you, nonpartisan coalition that I lead, we have been active, or our predecessor coalition, active in every provincial election since 1995, trying to get the strongest accessibility commitments out of all the parties. The Disabilities Act required the province to be led to be fully accessible, including the healthcare system, by January 1st of this year. The legislature unanimously voted to give the government 20 years to get us there. They blew it. We knew they were going to, unfortunately, because we could see it coming and warned them. But in any event, what we have done as a coalition is now called on all the parties to make what we call the Accessible Ontario Pledge, which details what needs to be done to get us to become an accessible province as soon as possible after the deadline as possible, the legislated deadline that was missed. Now, we're nonpartisan. We're not campaigning for or against any party. In fact, our goal is to get strong commitments out of all of them. So far, the Green Party made the Accessible Ontario Pledge. We have not heard back from the other three parties. As soon as we do, we will make it public. And we are gearing up for a Twitter storm to aim at all candidates to try to get them across the board on side with our agenda. But in the meantime, there are lots of things that can be done. Within the academy, a university like this has lots that could and should be done. We have an architecture faculty, which, if it is, unless it's any different from all the other ones in this province, does not require you to know how to design an accessible building to graduate. To lay people, that is absurd. We have various health faculties, health-related faculties, that are training the next generations of healthcare providers. We need to ensure that they include in their training the issues I'm talking about. How to provide barrier-free health service to patients with disabilities. When we talk, I can talk more about some of the nuts and bolts of this. I'm involved, I was at Osgoode, now at Western and at Ottawa, working on training law students on how to be able to affect clients with disabilities. I published an article some years ago with a blueprint for law schools called People with Disabilities Need Lawyers Too. Like a proposition you can't exactly argue with. I'm finding the faculty members and the students are really eager. Students want to learn this. Faculty members I've worked with are eager to teach it. I wouldn't be surprised if architect students would like to know how to design an accessible building. I wouldn't be surprised if medical students, occupational therapy students, physiotherapy students, nursing students, and all the others would like to be properly trained to serve not just the temporarily able-bodied clients, patients, but indeed the minority of everyone. This is so doable. We needed to start within the academy. The other thing we need, pending the province doing its job, is we need the regulatory colleges that govern the various medical or health professions to step up to the plate too. I met with all of their registrars or presidents before the pandemic. There was a real interest, but I can't tell you what the follow-up has been. I haven't been able to track it. But I know that I talked to very senior people at the College of Pharmacists about the accessible prescription label thing. I know for a fact that if the College of Pharmacists notified all of their licensees that within 6 months this is going to be an expectation and that they will enforce it, things would change. I know that when it came to the College of Physicians and Surgeons, and I'm not passing total comment on everything they do, but I know that during the pandemic, they gave their blessing to a critical care triage protocol sent to Ontario hospitals that was to direct how doctors were to decide who would live and who would die if intensive care wards were overloaded and the caseload had to be triaged. That protocol, we and others in the disability community publicly documented, was replete with unlawful disability discrimination. I'm happy to talk about all of this. On the resources you've got associated with this talk, our link is a link, I believe, to a talk I gave at Osgood a couple of years ago, detailing it extensively for the students. These aren't just statements, there's backing behind all of them. But we need to look to our regulatory colleges to step up the plate and do more. In the case of the pharmacists, actually require accessible prescription labels. In the case of the College of Physicians, certainly not to ever again give some sort of approval to a protocol that promoted disability discrimination in life and death decisions. Now, with all of that, I conclude by telling you that you probably think I am a total, complete pessimist. And the answer is not at all. I'm a complete optimist. I've been involved in this advocacy for over 40 years. I do it as a volunteer outside other activities, my career when I was working and so on. I have seen such incredible changes within the disability community, a young generation of people who aren't going to put up with these barriers. Law students, upwards of a third, 20 or 30% of the students at Osgood, Western, and U of Ottawa are registered as students with disabilities. And a number of them have said they want to fight this stuff. I see a lot of potential, and I don't know anyone who genuinely in their heart opposes us. If you'd like to learn more, as we are doing our dialogue, may I suggest two things. Number one, look to the links and the resources I've sent you. And number two, this is the magic moment where you learn community organizing. I'm going to ask if the list can be passed around. We maintain, the AODA Alliance has an email update list. And if you'd like to sign up for it, if you're in the room, just clearly print your email address. If you're online, you could do it too. You don't need our pad. Go to the following website. You can do it right now, www.aodaalliance.org, aodaalliance.org. And right on the homepage, there's a link where you can click to sign up for our newsletters. Put in your email address, and you'll start getting our updates. Had you been on that list yesterday, you would have gotten an announcement slamming the government for promising $1.3 billion for new school construction without requiring that the new schools be accessible. I'm not making this up. If you were on the list this morning, you would have seen a news release whose headline were words to the effect of, what future there will be in Ontario for students with disabilities is on the ballot in this election. We don't pull our punches. We offer constructive suggestions, we applaud where people do well, and we have something to say when they don't. Thank you very much for including me, and I really look forward to our discussion.
Very comprehensive overview that we will now dive into. Before we do that, I'd like to introduce amazing panelists that we have with us today, two junior fellows. I'm going to go briefly through your bios if you don't mind. The first person I'll introduce is sitting at the end is Allison DeCruz. She's a junior fellow at Massey College and a PhD student in higher education at the Ontario Institute for Studies in Education at the University of Toronto. And she specializes in education policy and international comparative education. Her area of interest and research are related to internationalization of education, international and immigrant student pathways, women in leadership in higher education, and private higher education. I'm just going to skip down a little bit here, if you don't mind. She serves as a chair and a member of several education-related national and international committees. And at Massey, she has been the co-chair of the Accessibility Committee and the Mentoring and Tutorship Program. So Allison will be asking David some questions in the first part. We're also joined by Rachel Tiley, who is a PhD student in laboratory medicine and pathobiology and also a junior fellow at Massey. She holds a Bachelor of Applied Sciences in Mechanical Engineering from the University of Waterloo, and her current research interests lie in investigating workplace occupational exposures, and her thesis is investigating how respirators fit to emergency service workers while they perform simulated work tasks. She is particularly interested in how personal protective equipment is not a one-size-fits-all for the 21st century worker. So welcome. I think I'm going to turn over the questions now in the interest of time, to you. And then again, we will be inviting questions from the audience here with us. So please feel free to let us know. And also for those of you online, I understand we have a mechanism to get your questions as well. So we look forward to the discussion. Thank you.
Thank you, Julian. Thank you, David, so much for your talk. And I think I could just listen to some of your lectures online. My first question to you is that we have significant shortages in our healthcare system, resulting in long wait times. And patients are increasingly being seen as numbers that need to be in and out of the system to make room for the next patient. For people with disabilities, that can translate to insufficient care as your system that you have isn't equipped to support the extra needs or maybe give them the extra time that they need. So what needs to happen to ensure that people with disabilities are not pushed to the bottom of the pile?
Great question. Two things. Number one, an effective healthcare accessibility standard could build features in to end run that. And the second thing is, thank God COVID is largely in our past. It's in our past as a pandemic. But unfortunately, the critical care triage protocol is not. They never had to invoke it. But what happened was that in preparation for the chance that it might have to be invoked, hospitals were encouraged to do practice runs. If you got a patient with so-and-so, what would you do? Which made sense. But the problem was it was training them to use a protocol that was unlawfully disability discriminatory, as if it wasn't. I'm not going into all the backstory on this. We have a whole link on our website, aodaalliance.org/triage, and you can see the media coverage, the letters to the government, the briefs written, the non-responses. But what we are worried about, and we've raised as a concern since then, is this embedded a mentality in the healthcare system that said that kind of disability-based decision-making is actually okay. And that's a huge worry. And we've said we need proactive, we gotta root it out. And related to that, and there is research on this, I've seen some of it, and individuals with disabilities can tell you stories, anecdotal stories, of what is politely called implicit bias or unconscious bias. Now, I want to be really careful here. I'm not talking about all people. I don't know them all. I'm not talking about most of them. I don't know most of them. Any doctor I've ever met really cares and works unbelievably hard and is really dedicated. But lots of people with disabilities can tell stories where from our radar there was some kind of sense from some healthcare providers that viewed disability as somehow a lower quality of life. And when you give me a question which basically talks about how do we deal with backlogs and shortages, there is a risk that some people with a discretion over who's going to move up and who's going to move down on that, there is a risk that some people making those decisions could be influenced by unconscious bias that devalues the quality of life of a person with a disability. And it's not enough in response to that to just say, please don't, and have people say, I won't. Because the nature of implicit or unconscious bias is that it's implicit and it's unconscious. And when those decisions are not made in public, like when a judge is in a courtroom, and with written reasons, like when a judge is rendering a decision, but is simply in meetings or as they're setting schedules, this is really hard to police. So it's something that requires a not only the regulation, but a proactive strategy to reverse what we know can too often happen.
Okay, I'm going to turn it over to Rachel now.
Thank you for your talk. I have a question about our comparison of disability in healthcare in comparison to other countries. So you've mentioned the prescriptions in America. Are there other countries that we can look to that sort of...
I'm not qualified to answer that.
Okay.
We just, as a volunteer coalition, we don't have the capacity. We'll get some anecdotal news from here and there. I know that in the States there are stronger accessibility laws in some areas, and that they are far more effectively enforced than elsewhere. And so, by definition, that's going to help. Now, my colleagues in the States will tell you there's still lots of problems, and God knows they have other problems in their healthcare system because of it's private and there isn't an assured public insurance regime. But it really, I would frankly I'd welcome international research on it, comparative research, and we'd probably need to look at different systems and also through the perspectives of people's different disabilities, because this is not all or nothing. They may be good on one, but not as good on another.
Oh, okay. So I guess you're talking about like this could be a research gap that can be looked into from an academia perspective.
It certainly could be, but you know, I mean, the first thing I'd want to do is look at what different regulatory measures have been tried, what different practical strategies are there. I mean, the American Hospital Association, the American Medical Association, I've not gone to their websites. If they've got good best practices, I'd then turn to the CMA and so on and say, you know, why aren't these here? Do you follow me? I mean, there may be, it may not be as much empirical research in terms of sort of who's being better served, but just we know what the barriers are. Who's come up with solutions?
Just to follow up on that quickly, in your previous talks, you've talked about how inclusive, as an example, Apple and iOS have been in terms of their inclusive design. I was wondering if you could sort of comment on how we could include that inclusive design in healthcare, and you've kind of touched on that with looking at different hospitals and how they're built.
Sure. I mean, first, universal design in designing a building. That would be a really nice start. So just down the street from here is the new Women's College Hospital. They tore down the old one, they built a new one. We had the mayor and the premier and the prime minister, all big smiles when they opened it. And a few weeks later, I went in with a colleague from my coalition and we started looking around. So there's a men's washroom, there's no Walmart greeter, and finding your way to the front door to somewhere to help you is an issue. But on the main floor, there was a men's room and a women's room. And what's great is they had a Braille sign in front of them, each of them too. Isn't that, you know, that's good. So I read them. You know what they said? something like 1441 and 1442. Now, folks, how many of you know the room number of the bathroom you use today? How many of you ever been told, oh, you need the men's room? Go to room 1141. I mean, what? This is not rocket science. This is just stupid. On the second floor, if I remember, that's some time ago. And by the way, we took a reporter through and got news coverage. They had designed a parking area to be accessible. That's fantastic. And then you come in the doors, I think it was on the second floor, and there's an electronic kiosk to pay for the accessible parking that is at standing height, built into the wall. Okay? Like, and there was somebody with a wheelchair, like, couldn't get to pay for parking. I hate to sound like a broken record, but this is really stupid. Like, how on earth are you supposed to? I mean, somebody had to design it and say, this is where we're putting it, and not apply basic thinking to put it that way. And it's not, oh my God, disability accommodations, they cost so much. Just build it in the wall, but 2 feet lower. It wouldn't have cost a single thing. So I'm just giving you a couple of examples. If you go to a hospital, you know, and I gave a grand rounds talk this morning to the pediatricians, number of the other staff at Sick Kids Hospital, which for me was a phenomenal opportunity. I was really excited and really well received. And I talked to them somewhat about what's involved in providing barrier-free healthcare, but I was more busy talking to them about being systems navigators to help, barrier busters to help families of kids with disabilities just navigate the healthcare system and navigate the education system. Do you follow me?
Yes.
There are solutions which could make things better, but what you need is to stop leaving it to each healthcare provider and each institution to have to reinvent the accessibility wheel. You want to invent it once, and that's called the Healthcare Accessibility Standard.
Thank you. Okay, we're going to move along here because I know that there might be some questions from the audience. So we're going to, great, I'll get to you in 1 second. I'm just going to let Allison ask a question, and then we have someone from the audience, which will be great, and you can introduce yourself after. Thank you.
Perfect. So, David, you spoke about devalues quality of life. And I wanted to, so I'll give you an example. Yesterday, I probably spent 4.5 hours getting a family member who's wheelchair bound to a doctor for a test and a quick consult, something that probably shouldn't take you more than 45 minutes. But I had to do, these 4.5 hours was, waiting for your transit to show up, and that means you need to be ready an hour before, and they may come within a half an hour window. And I kind of want to just stress about the quality of life. Like, do the supports that we have for people with disabilities, do they consider the quality of life? For example, do these people maybe need time to do other things in the day, as opposed to we are supporting them, but that just leaves them with pretty much nothing else but to, go to a doctor's appointment the whole day.
Add to that a chronic fatiguing condition?
Yep.
Or a chronic pain condition?
Yep.
Or going for chemo, and therefore they're exhausted, or it's just not a good day? The answer is like, no, not enough. Not enough. If we look at our public transit system, people with disabilities are second class. If we look at the education system, I'm the chair of the Toronto District School Board's Special Education Advisory Committee. I've sat across from the trustees and said, in one way or another, that our students with disabilities at the school board are treated as second-class citizens. Not that anybody wants to. The teachers want to teach all learners. The principal's the same. It's a broken system, not broken people.
I'm going to just interject here
Sure.
and say it is a broken system, but people have to be held to account as well. I think that's really important, and I appreciate that you're not identifying any individuals per se, but what you are raising are some very deeply concerning, as you point out, things that could be fixed not with a lot of resources and not necessarily with a lot of time. So I want to make sure that we have the audience participate, and I see there's a question. We do have a microphone, so yeah, if you can just raise your hand, introduce yourself, please, and thank you for coming.
Okay, hello everyone. I would want to stand. My name is Beatrice Sanajo. I'm from Ghana, and I'm a journalist. I've been practicing for 18 years, and my focus has been on disability reporting and orphan children living with HIV and a whole lot. But since we are talking about disability, I was expecting to see that we would see a lot of people here, but I mean, it's a good way to start, because issues of disability are really not taken seriously from where I come from. So I was thinking that when I go here, I would see a lot of people, because it starts with us. If we want to see change, it starts with us. Now my question, I would want to know, when it comes to enforcement, in Ghana, it is a law that people who are building, or any person putting up a building, should make sure there is accessibility to enable persons with disability to move around. Even with that, it's not done and nobody is enforcing it. I would want to know, if that is the case here, how is the enforcement being done? Are we adhering to the rules and regulations concerning the architectural system in Canada? Yesterday I went to do groceries and I saw a lot of people living with disability, wheelchair bound, and I was wondering, because now that I realized that the accessible ways for them were so steep that it's very difficult for the person to move or travel the place. So I was wondering, how are we including them? As the speaker said, it is an afterthought. So that was what I realized, that it's an afterthought. What are we doing to ensure that the laws are enforced? Thank you.
Thank you. It's great to meet you. I could talk to you at length about disability and journalistic coverage, because we're very busy trying to get it. I see there's a new generation of journalists who are more interested in covering it, but we have, and I don't want to oversimplify this, but some of the papers in this city don't cover it at all. Or if they cover it, it's not in the Queen's Park coverage of political issues. And in fact, our news release that went out this morning, you'll see right at the top of our What's New page, one of the things we said is that we are calling on the media. The media in an election usually boil the case down to 1 or 2 or 3 issues. In this one, it's going to be probably Donald Trump, and Donald Trump. And the parties play their own strategies for what they want people to be asking about. But we have a lot of trouble getting attention. The hardest time to get media attention on political disability issues is during a provincial election. It's I keep saying absurd. That's where we live. Okay, and we're trying to change that. With respect to enforcement, on our website we have a whole page, a web page, aodaalliance.org/enforcement. The enforcement of our Disabilities Act across the board has been very poor, very weak, making compliance essentially voluntary. Even though we were promised effective enforcement when the law was passed. The law has enforcement powers, but they're not very useful if they're not used. You asked specifically about the built environment. So let me do this briefly. We have a building code that is supposed to address accessibility. It only deals with new buildings or major renovations. And its accessibility requirements are absolutely up to date to the early 19th century. And every once in a while they do an update to move it maybe a decade forward. We'll be close to the US Civil War, maybe in my lifetime. It is pathetic. And if you try to talk to them about fixing it, you get kind of blank stares. And architects overwhelmingly are trained to essentially do building code. I'm kind of simplifying, there's a lot more I could tell you, but let me just tell you, if you want to learn more, just Google the following 4 words: $1 billion accessibility bungle. There's a new courthouse not far from here on Armory Street. It cost the government just a little shy of $1 billion, and it is replete with accessibility problems. They could have done it within the price of the building. They could have fixed these. They can't say we weren't told, because in the video you'll see snapshots of letters we wrote before shovels ever went in the ground, warning them about the barriers they were going to build. And if you go to our website, you'll see media coverage of a report the government commissioned after it was built, confirming some of our conclusions are actually correct. That ended up on the front page of the Toronto Star when we gave that report to them. So part of the problem is the legislation, but as well we have governments that are willing to use public money to create new accessibility barriers. And our Accessible Ontario pledge that we're asking the parties to pledge, one of the commitments is that they'll stop doing that.
Okay, there were a few more questions from the audience, so thank you again for helping
I'm going
out.
to be really short with my
Okay,
answers.
well, we're good for time, but we're going to just make sure we get to everyone who has a question. And if you don't mind introducing yourself, thank you.
Hi, David Slowly. I'm a volunteer at Massey, but I was a volunteer for 20 years at York with the Disabilities program, and sat on the first committees at York and Carleton to establish policy at York and Carleton. What was interesting is seeing, this is 1982, 84, seeing and going back to York 20 years later and listening to informal conversations and looking at level of services between those two periods. And there was tremendous change in terms of the extent of services for people with disabilities in the 20 years. But what was interesting was that the attitudes in many cases hadn't changed, because I was able to sit with and listen into informal conversations between professors and accommodation questions, and I was still hearing the same kinds of informal conversations that I heard 20 years before. So I'm wondering, to what extent is someone doing research on the attitudes towards disabilities? Because politicians, in my experience, I work in politics, don't move until there is a sense that the populations are demanding the kinds of policies that they might offer. Who's doing research on where there are gaps in awareness and acceptance of the value of accessibility?
I can't give you a direct answer because I don't know what research is out there. I can, however, give you a new approach to this that my coalition has been trying to bring for some years. If you read that memoir I mentioned I wrote, Swimming Up Niagara Falls, and I want to emphasize, I really want you to download it for free. People shouldn't have to spend any money. I quite deliberately chose an avenue to make it as widely available as possible. I talk about the fact that in the 70s, the common approach or view or argument for the disability community was that the biggest problem we face are other people's attitudes. And this was revolutionary at its time, because back then when people looked at a blind person, they thought the biggest problem we had is like we can't see. We said, no, we're fine. We can live full, happy lives. Our problem is your attitudes. Not you, but sort of the notional collective you. And this gets in the way. Now, this was revolutionary for its time. I didn't invent it. I heard it. I believed it. I said it over and over. Lots of us did. Some people still say that now. I never do. Why? Because the chain of reasoning it led to was the idea, oh, the problem is people's attitudes. The solution is to educate them. Let's raise awareness. So people wheeled their wheelchairs around the world and did those kind of stunts and saying, I'm trying to raise awareness. Okay? Do you get from my tone of voice I don't really like the concept? I don't, because it doesn't work. We've all tried it. Governments have tried it. Disability service organizations have tried it. Disability advocates have tried it. People laugh at your jokes and go back to business as usual. it doesn't work. Some people may change, but it doesn't work. What we found was that if you want to change behaviors, don't try to first change their attitude. I've heard people say, first we need a culture change. How do you measure that the culture has changed? You can't. And it won't happen in our lifetime. What you need to do is change action, and the attitudes will follow. So we don't talk about raising awareness, we talk about raising action. And when people say, will you come and do some awareness raising? And I say, no. In fact, what I've tended to say is the best way to raise awareness is a mandatory, effectively enforced law. Or in the university speak, what's the first question that students ask that will get their attention, how it's answered? Is it on the exam? If it's not on the exam, I'll worry about it later. That's called mandatory and effectively enforced. The practice changes, and then the attitude follows. Now, what you've posited isn't contradictory to this, because you're saying that until people have a different sense of it, they won't push politicians to change it. Well, that's part of our political strategy too, because when you heard me do my little shtick that I do every time I give a talk about raise your hands, what am I doing? So I'm roping you into our movement. Okay? It's not them anymore, it's us who are being hurt. And the more we get us unhappy with the government failing to serve us, the more more politicians are going to follow. It's not easy, believe me. But, and the other thing that we do as a strategy is we try to take political action on things that you can't possibly say no to. Like when I say don't use public money to create new disability barriers, nobody will think that that's a bad idea. Everybody will think using public money to create new disability barriers is remarkably stupid policy. So you frame our asks in those kind of terms, and that's what we do. And if you look on our website at the Accessible Ontario Pledge, everything we put in there is something we need, but everything we put in there is something which you would look at a politician if they were sitting across from you, and even if they didn't want to say yes, they'd feel like really bad trying to tell you that they want to say no. Do you follow me? So it's a political strategy to get around the thought that first we've got to change attitudes and then we'll get our problems solved. I hope that helps.
Okay, we're gonna, Rachel, you want to?
Yeah, I just wanted to follow up on that. So really quickly, so as you know, as we spoke before, I do work with occupational environmental health, and within the legalese of occupational environmental health, there are rules that you have to follow for workers to be safe. Is that sort of what you're sort of looking at with in terms of enforcement for the AODA? So for example, if I felt unsafe at work, or I felt that I was asked to do unsafe work, I can rightfully refuse. And that's very baked within the culture of employees. Is that also what you're sort of looking at in terms of enforcement?
Well, when we were working on developing what the AODA should be, from 1995, when Mike Harris was elected, to 2003, we were dealing with a government that said, we'll pass an act, but it won't have enforcement. 2003, a new government got elected, led by a guy named Dalton McGuinty, who said, we'll do a good law and it'll have effective enforcement. What do you want? So I quietly said, oh, hell, what do I do now? So what do? You look for smart people who could give you advice. So I've been teaching as an adjunct at UT for a number of years, and I approached a young, brilliant administrative law professor, now on the Court of Appeal. In between, he was the dean at Osgood, and now a very good friend of mine, Lawrence Lawson. And I said, here's the problem. We need to come up with some alternatives. Will you essentially head up a brains trust? And he pulled together about 3 or 4 UT law profs. This is all off book. There was no budget, there was no grant, we just got together every couple of weeks and we brainstormed. And we looked at schemes like occupational health and safety and environment as the closest regulatory schemes. Because I couldn't find anybody who looked at comparative regulatory schemes in the law biz and said which one actually works better and why. So we sort of just tried to build this ourselves and plucked ideas from each. But there's still tons of room for more ideas to make it more effective. One of the ideas we came up with, just to give you an idea, one of the things that we know in the criminal law is not just the severity of punishment, but the extreme likelihood of punishment. People are less likely to offend if they know there's a very good chance they're about to get arrested and prosecuted and convicted. It's intuitively obvious, okay? If there are cops on the highway, you're less likely to speed. So what we said is we need kind of more face time, not the Apple version, for enforcement. So how about if we got the government to deputize inspectors under a whole bunch of different acts, different areas like occupational health and safety, and give them a short list of AODA stuff they could check for while they're checking out for an occupational health complaint. Look for these 5 accessibility things. And if organizations knew that could happen, that meant that the likelihood of enforcement all of a sudden comes much more close to home, and it would work. So what happened? The liberals tried it, 13 years ago with some. We've never got a report of how it worked. We now have it in our Accessible Ontario pledge to ask the next government to try it again. Just one idea.
Thank you. Okay, I know there was another question in the audience, so over here, please. Thank you. If you don't mind introducing yourself.
Hi, David. Thank you so much for your talk. I'm a registered nurse. I appreciate that your work, or at least your talk today, is mostly focused on systems problems. But I'm wondering how, at the individual level, healthcare providers can make healthcare a safer and more accessible space for people with disabilities.
Number one, every healthcare provider should build into their practice a commitment that I want to be an accessible healthcare barrier buster. And what I should do as a very start is I want to create a welcoming environment in which patients can seek and receive accommodations. Patients don't know they can ask. So every interaction that you have with a patient, if you were providing direct care, whether you're a nurse, doctor, dentist, whoever, say, I want to make sure my health services are fully accessible to and accommodating for patients with disabilities. If you have any disability accommodation needs, if there's anything I can do, I'll do my best, just tell me what you need. If that were part of the greeting at the door, if the receptionist asks that routinely as you're making appointments, because it's better to know in advance. If it was on the voice response system, if it was part of the sitting down in the first interaction, even at bedside if you're doing rounds at the hospital. Just that alone can be transformative, because people don't know they can ask and don't know they should expect. I shouldn't say people. Some people, a lot of people, don't know they can ask and might be afraid to ask or think that this would be seen as being uppity.
Thank you. I'm mindful of the time, and I see that we have 2 questions from the audience, so we'll get to you, I promise. I just want to turn it back to Allison, because she's got a question to ask you from the panel. David.
I'm going to be really brief.
A bit of a follow-up to your question, and considering where we are at Massey College in the middle of the University of Toronto. I want to know, what can we as students do to ensure better access to healthcare for people with disabilities?
Come up with a short list and start going to the various faculties, action lists, and start going to the health-related faculties here and see if there's a way to talk to students about it, or faculty about getting it raised with students. Ask them what they teach about addressing the needs of patients with disabilities. Talk to them about whether they should be teaching something. There's tons you could do. And heck, your students, ask good questions. And if you don't like the answers, you know what to do. You're students. I think there's a ton of good things, but giving them, I firmly believe in not only pointing out where there are deficiencies, but coming up with constructive solutions. And frankly, if you go online first, and if you could find that there's some medical school or OT school or nursing school or something in the States, and they're doing a bunch of this stuff, and then you look online at the what's offered here, and they're not going in and saying, hey, why, just curious to know why you guys don't do this, or whether you think it might be worth trying.
Thank you. Okay, we're going to go back to the audience now.
Hi, thanks very much for your talk. My name's Emma. I'm one of the junior fellows, and I'm a surgical resident in plastics and reconstructive surgery. So just a couple, like, kind of to follow up on your question previous. So in our domain, we are involved in hand reconstruction and pressure sore reconstruction. And so recently, maybe the last 5 years, the government stopped funding hand therapy. And so a lot of the procedures that we do to improve hand function, which for people, so many of them who are on workers' disability or disability, it's a moot point to do those surgeries without hand therapy. And many people are on disability or around the poverty line, and they can't pay for occupational therapy. So the surgeries that we can offer will not be helpful to them. And so it's this weird paradigm where the government won't support occupational therapists to rehab our patients, but then these patients then still sit on disability and government funding. Similarly, with patients with pressure sores, they don't have the supports to heal or prevent follow-up wounds, so we don't reconstruct some patients because with the resources that are currently available, we know that they're going to relapse and have another wound, so we just manage them with wound care. And those are, so from a surgical perspective, like, I'm pretty sure that people, I was a med student at the time, tried to rally against that, but how, as a soon-to-be plastic surgeon, could I engage with people like yourself to try to change that?
Okay, this is, I didn't know this. It's disgusting, but as with everything I deal with, not surprising. Longer conversation I can do in a short thing. We could have a longer call if you want to reach out. My contact info is on the sheet. But let me, and I'm also with the election really overloaded, so I don't want to just say call me and then I'm not able to talk to you. Let me give you a few things. First, this is, if I was framing the argument about this, I'd say this. We have a belief here that if you see somebody with a disability here, there is no medical solution, because if there was, we could provide it. If you see me and I'm blind, you got to rest assured there's no treatment available for my blindness. There is no medical treatment. If you were in certain developing countries, you'd see blind people who could well be completely cured, but they don't have the medical infrastructure. What you have just described is more like that developing country than here, that impoverished country than here. And I would make the argument that this is not just an omission, but a categorical failure. And I would then be trying to put together, if I want to reform this, what you need to do, and this is what we do in the kind of social justice advocacy thing, and it would be cool if you got to some law students who wanted to put together as I know at Osgood, they don't do this here, but Osgood has a requirement that students do pro bono placements. This would be a fantastic one. To put together a case to go to politicians saying, here's what it would roughly cost to address this. Here's the potential numbers. And I don't care if they're studied and triple checked. They could be estimates. But here are the number of people who are going to be on disability rather than working because of a medical procedure and follow-up therapies that we have in the province, but we will not fund for them, leaving them into poverty and social dependence. Then here's what it would cost to fix it. In other words, we need X amount of surgery and Y number of hours of OT. I would then think about, seriously, if we could find a foundation that would fund a pilot project, because if you could come up with a pilot project to try it out with 10 people and show it works, and then And then it's a combination of getting it to a political party that's in opposition if they want, that would want to push it, or a government party that was in opposition and wants to do better than the last guys. Do you follow me? And then you make the pitch. But it's a bite-sized strategy. I mean, I know of something close to this, just close, near and dear to my heart. I have a friend who broke her arm, and it's healing, and no one told her about any resources over the 6 weeks that she can't work with one arm, about how to do stuff with the other arm. Well, I happen to have a friend who's got only one arm. That's the way she lives. She said, tell her to call me. I went on Google. I found some resources. Like, there are resources. Forget funding services. There's stuff that's free and out there. And we're not necessarily connecting that up to people. And it really affects their lives. So this is, what you're talking about has a crisp, identifiable category of people who need it, a crisp, identifiable, and limited amount of service that would be needed to address it. I think you've got a really compelling case. And if you didn't get anywhere, I mean, what I would be doing is connecting it up with a couple of reporters at the big media. And if they don't pick it up right away, you go to one of the online publications, and they pick it up, and then the big media does. There's like ways you can make this happen.
Okay, thank you. I know we have another question from the audience, and I think we have time for literally, unless there's a compelling question, or maybe, David, you'll be available afterwards. But I think this is going to have to be, just in the interest of time, our last question. So please go ahead. Thank you.
Okay, first of all, hi, Professor. How are you doing? Okay, so that's good to hear, and thank you for your words. So I'm Hania. I'm 23 years old. I just recently finished my studies in software engineering. So as you were speaking, I'm really thinking of this from a technology perspective. And so I did know a lot of the technology aspects that you did mention, like, for example, having prescriptions that are scannable, and having apps that are able to read this out to you, or having like parking apps. I know Alberta specifically has a AHS parking app, which I recently found out when my sister went into labor. So that was really nice. But like you said, I don't think any of the staff inside of the hospital knew of this. I also noticed that you mentioned Apple and iOS. And you also just recently mentioned having discussions with students, and students can come up with amazing ideas when you fostered that discussion. Now, especially from an engineering perspective, it is super important that we do have the correct problem definitions to be able to foster these discussions in the right direction. Otherwise, we might not be addressing the problems that are at hand. So my question to you it's like multifaceted, but what would be some of the problem definitions to direct these discussions? What do you think that, or how do you think the technology can contribute to accessibility barriers, and what rules or regulations do you think can be implemented within or for technology companies that can help better implement accessibility?
On my hip is an iPhone. Well, let me say this. The experience of blindness transformed in my lifetime. When I was in law school, I had to have human beings read things to me. My phone or my computer now reads things to me. It's rare that human beings read things to me. I remember those days. My phone can scan a document and read it to me in seconds for free. And in 1981, when I was at Harvard, I saw the Kurzweil reading machine, the first device that could do this, that filled your desk. It cost $50,000 US back then. More like $150,000 now. These are transformative. I have the Meta smart glasses where I can say, hey Meta, look and tell me what you see, and it describes the room. I was at an airport departure lounge. They announced they changed the lounge number. I wasn't sure if I was at the right one. Hey Meta, look and tell me what lounge I'm in. It said 18. I sat there. I was in the right place. That's my glasses. They cost $400. What we need, in terms of regulations, we have an information communication accessibility standard under the AODA. It was passed in 2011. It was good then. It's way out of date now. On the government's desk for 3 4 years are recommendations on how to strengthen it from an expert government-appointed panel. They've done nothing. It doesn't even apply right now to mobile apps because they didn't exist back then. We know what they need to do. But in the university, I'll tell you what we need, especially you as a student in software engineering. We need to have courses. We need to have mandatory courses on accessible human-computer interface design. I got a friend who teaches that at University of Maryland. Does anybody teach it here? It should be required. Anyone who's getting a degree to design software or any kind of hardware should be required to know how to design it to be used by all people. We don't. If we did, and I've told the government this for 10 years, I lost track. We could have a supply of expert software, hardware engineers selling their skills around the world because the demand for this is growing in the US, in Europe, in Israel, eventually in New Zealand, England, Australia. It's a huge demand and growing. And instead of us dealing with it, we just keep training more people who don't know how to do it. Doesn't make sense.
Okay, on that note, I think we're going to have to conclude our discussion for tonight. Of course, I want to thank David for his time and insights, my amazing co-panelists. A definite thank you to the team here at Massey. So thank you, Alyssa Ginsberg and Joe and the tech team back there. So thank you so much. Thank you for all of you who have shown up for today. I hope you take one key message from this and integrate it into our lives. There was a lot that we heard, and I'm very hopeful. I'm going to take David's words that he's optimistic. So David, if you're optimistic, I think we have something to work towards. So thank you for that.
Thank you very much for including me. And just to end on the right note, you have 2 senior fellows here who are among the finest judges I have ever known. And I'm blessed to have as friends. Get to know them. And they're incredible people and incredible talent. They bring law together with justice and wisdom, and that's not easy. Thank you all very much.
Great, thank you.